Good morning, everyone. I have the pleasure of kicking us off this morning. This is Steve Bradley. Myself and Santiago Garcia today will be speaking about registries that are being led out of MHI and MHIF that deal with cardiovascular disease and COVID. The registry I'll be speaking about is the American Heart Association COVID-19 Cardiovascular Registry. I do sit on the steering committee of that registry. So in case you've been under a rock for the past 3+ months, let's first talk about what so COVID is a severe disease caused by acute respiratory syndrome coronavirus 2 or SARS-CoV-2. First emerged in Wuhan, China in late 2019, identified at that time. There's been subsequent global spread. Common symptoms include fever, cough, and shortness of breath. There are other fevers that can be associated, malaise, body aches, fatigue, nausea, vomiting, diarrhea, loss of sense of smell is one that's been reported and appears to be relatively pathognomonic and potentially associated with less severe illness. But the more challenging thing can progress to severe illness in a proportion of patients. I've been speaking on this with relative frequency of late and used this slide to introduce this to a lay public talk about a week ago. And at that time, we were at 1 million fewer cases and 100,000 fewer deaths. So clearly a global pandemic that's spreading broadly and disrupting lives in tremendous ways. There's also a lot of misinformation about this disease. So when I went to look for lay public slides to try and share, the first thing I came across was at the World Health Organization website, which had a slide about how 5G networks do not spread COVID. Now, clearly, if we need to explain that a internet network or a mobile network doesn't spread a viral disease, and if leaders are talking about ingestion of disinfectants, we have a problem about clarity of message. Hopefully, I'll be today as it relates to cardiovascular disease and COVID and what we're looking to try and understand. So why is there an interest first in COVID-19 cardiovascular disease? This first stemmed from an understanding about how COVID invades the cells. And so its spike protein binds to the ACE2 enzyme. So ACE2 enzyme is involved in blood pressure regulation and regulation of the renin-angiotensin system. It's both bound to the epithelial layer of the cell and found in throughout the body, and predominantly, particularly in the lung epithelium. There's also a soluble circulating form, and it's responsible for breaking down angiotensin 1 and angiotensin 2, the byproducts that do not cause vascular constriction and hypertension. Knowing this, there was concern that ACE inhibitors and ARB be associated with disease, infection, and severity. It's known that use of these medications cause upregulation of the ACE2 enzyme. It was thought that potentially some of the evidence that coronavirus or SARS-CoV-2 was more prevalent in patients with hypertension related to this effect. But at the same time, it's postulated that upregulation of ACE, particularly the soluble form, could result in a competition and bind up the virus in the bloodstream and prevent it from entering the cell. So there's these conflicting hypotheses as how these medications could contribute to coronavirus infection very early on, and a lack of clarity in terms of which was the appropriate direction to go. And then observationally, we began to see a strong association between cardiovascular disease and COVID outcomes. So the first two of the larger studies coming from China, one published in Lancet, one published in JAMA Internal Medicine, first looking at 191 hospitalized patients with COVID-19 and characteristics with survival. So amongst these 191 patients, 54 survived. 54 were non-survivors. Non-survivors were older, 69 relative to 52. A higher predominance of being male. And again, it's known that men are more likely to express the ACE2 enzyme at higher levels, and again, raising the concern about interaction with that enzyme. And of particular note, patients with hypertension were twice as likely to be non-survivors, or twice the prevalence of patients with hypertension and non-survivors Coronary disease, 24% in non-survivors compared to 1% in non-survivors in survivors. And then finally, diabetes, 31% in non-survivors compared to 14% in survivors. When they looked amongst patients who progressed to ARDS in a 201 patient population in China again, patients who progressed to ARDS were older compared to 48. Again, a higher predominance of men instead of sex, that should read men, 71% to 58. And then hypertension, again, 27% amongst patients with ARDS compared to 13%, and a higher prevalence of cardiac diseases and diabetes. So again, raising a strong concern about an association between cardiovascular disease and COVID outcomes. We've also seen an association between COVID itself and cardiovascular events. So instead of cardiovascular disease being associated with COVID, COVID being associated with cardiovascular events. Amongst the first that's been reported was this issue of cardiac injury. Now, cardiac injury is challenging because it's very nonspecific, typically being elevated troponin. We all understand that elevated troponin is not a specific finding and can reflect anything from true acute coronary syndrome to release of the enzyme from myocardium that's unhappy in the setting of severe hypoxia demand, non-acute plaque rupture settings. Also going to be myocardial depression in the setting of severe COVID illness with inflammatory response and potentially myocarditis. But if you include all of those patients, they found that 20% of patients had quote unquote cardiac injury, meaning an elevated troponin, and those patients were much less likely to survive. Their survival rate was 50% compared to upwards of 90% in those patients without cardiac injury. And I apologize for the additional noise. That sounds like my dogs may be coming downstairs to go outside for the morning. So case reports were also seen of patients with myopericardite and stress cardiomyopathy. So this was a case report published in JAMA Cardiology, where it was actually a patient who was doing well at home, had no symptoms of COVID, no viral illness symptoms, but presented with fatigue and shortness of breath, and was found to have non-specific changes on her EKG, as well as mild troponin elevation. She was hospitalized and found to have reduced ejection fraction. Her subsequent MRI imaging demonstrated evidence of edema and late gadolinium enhancement consistent with myopericarditis. So similar to other viral infections that can cause myopericarditis in the absence or relatively mild viral illness, again, we're seeing similar can be observed in patients with COVID. The exact incidence and prevalence of this is not clear at this point, but clearly can be associated. Last week was published another concerning finding of patients, very young patients with large vessel strokes. So this was a case in the New England Journal of 5 patients under the age of 50 who had large vessel strokes. Another single center study from China reported approximately 5% of patients hospitalized with COVID had evidence of a stroke. Very concerning, and concerning that this disease may be associated with increased thromboembolism, both arterial and venous. There's been reports from other settings of a high prevalence of venous thromboembolic events in critically ill patients, and some thoughts that perhaps more aggressive anticoagulation could be beneficial. That thought predominantly comes from a single center study in China that looked at patients who received 7 days of anticoagulation with therapeutic heparin, either unfractionated or low molecular weight, versus those that didn't, and observed mortality benefit in those patients who received heparin. So heparin being the blue bars, non-heparin being the red bars. The challenge is they did not differentiate the timing of the initiation of heparin relative to when the patient came in the hospital and when they became critically ill. There's concern that perhaps more aggressive venous thromboembolic protection in the form of pharmacologic therapies at admission is probably particularly important and would prevent the need for full dose anticoagulation later on. The right balance isn't clear, and there's clearly risks associated with full dose anticoagulation. So currently recommendations are for pharmacologic anticoagulation, pharmacologic prophylaxis in patients who are admitted to the hospital. Oftentimes, if those patients were ambulatory, we would say that might not be necessary. It's different for COVID. There are also concerns about proposed management of cardiovascular disease, proposed management of COVID and how it relates to cardiovascular disease. And some of these proposed therapies have just in the past week fallen by the wayside, but speak to the continued importance of paying attention to therapies as they evolve and their potential interactions with the cardiovascular system. So two of the proposed early therapies for COVID were hydroxychloroquine and chloroquine on the basis of in vitro studies that demonstrated suppression of the virus. This received a lot of lay press attention and essentially was starting to become standard of care because patients were demanding it. Evidence supporting its effectiveness or its efficacy. Recent publications just again in the last week looking at hydrochloroquine, azithromycin, and QTC prolongation. Azithromycin is another of these medications that had been proposed effective despite high quality evidence. In this publication, they found that 90 patients treated with hydroxychloroquine plus or minus azithromycin, 20% of those patients had prolongation of their QTC to greater than 500 milliseconds after initiation of therapy. And one patient was noted to have torsade, so not without risk and in a disease state that for the vast majority of patients, supportive therapy will be sufficient. Use of these therapies, there's clear trade-off and risk. Another publication published a week and a half ago, Friday, in the journal that I serve as an editor for, JAMA Network Open, was looking at high versus low dose chloroquine in a Brazilian study. Because of essentially being adopted as part of routine practice, they did not have a placebo arm because they were using this in compassionate use. Similarly, all patients in this trial were on azithromycin, and there's concern about additional prolongation from using those two medications together. The intent was to enroll 400 patients and to look for benefit, but as part of reporting to the DSMB, they reported mortality on a daily basis, and their study was terminated after enrolling only 80 patients because of a higher rate of mortality in the high-dose chloroquine arm. So this is no longer supported, at least in the setting of addition of azithromycin, and increasingly the evidence is suggesting that these therapies may not be beneficial. I've seen also from folks who are trying to enroll patients in these trials, and they've gone from having difficulty enrolling anyone in the placebo arm because patients were unwilling to be enrolled in the placebo, now to the point that they can't enroll anybody in these trials at all. It speaks to the fragility of clinical equipoise as we try and generate data and evidence about what is best for these patients. In the reverse arm, we talked about COVID management and cardiovascular outcomes. There's also concern about what's the right cardiovascular management as it relates to COVID outcomes. I spoke about the hypotheses related to renin-angiotensin system and inhibition of the system as it relates to COVID. Just in this past week, trials were published that suggest that there is no mortality associated with the use of ACE or ARBs prior to infection or prior to hospitalization, and no association with mortality once a patient is hospitalized. So the study on the left is looking at patients who had hypertension, and this is again from China, and whether those patients on hypertension were managed with ACE or ARBs or without ACE or ARBs, and what their illness severity was. Encouragingly, patients who were on ACE or ARBs were a higher risk population, so a similar age, but a higher prevalence of being men, higher prevalence of prior stroke, higher prevalence of coronary disease. All of those factors would weigh against this patient population and suggest that in an unadjusted analysis, you would expect to see worse outcomes in the ACE or ARB population. In fact, they did not see a difference, and so provides additional reassurance that continued use of ACE or ARBs in patients who are hypertensive on these therapies is the right thing for now, is to continue them on these therapies. And it comes back a little bit common theme for right now. So I think a lot of us see a disease state for which we don't know what the best thing is. We feel somewhat impotent in the sense that we lack therapies or we lack knowledge about what we should do, and we start to glom on to the first thing that comes down the pike about what might be effective. I think we need to be regimented about understanding that we first do no harm and have the willingness to, rather than just standing there and doing something, instead don't just stand there. continue to gain knowledge and understanding, provide supportive care, and be very thoughtful about application of therapies in terms of application or removal of therapies in terms of what the risks and trade-offs are. And it turned out that the right approach here was, again, don't do something, just stand there, continue patients on their cardiovascular medications. They have benefit for them as it relates to their cardiovascular disease. And it turns out that it does not offer harm as it relates to COVID, at least from the available evidence thus far. As it relates to ACE and ARBs on admission, so this was a paper published in New England Journal on Friday. Tim Henry happens to be a co-author on this paper. Again, no mortality signal amongst patients who continued on ACE or ARBs on admission. When I saw this figure, so here's the forest plot by subgroups, and again, we see ACE inhibitors actually lower risk of mortality by the point estimate and confidence intervals. ARB overlapped 1. I reached out to Tim and I said, where are beta blockers? That would be your falsification analysis. You would expect that, given our understanding of how COVID interacts with enzymes, the ACE2 enzyme, and what the implications are, that we wouldn't expect to see an association with beta blockers. But if you did, it would suggest that the observed association relates to the severity of illness of patients coming into the hospital. If ARB had it taken off, it may be because they were hypertensive and particularly septic. And so the observed effect size wouldn't be related to the medication, but an indication bias. So I reached out to Tim. I said, where's that analysis? And they pointed me to table 2, where beta blockers, there was no effect observed. There was similar mortality amongst patients who were and were not on beta blockers, whereas there was a mortality benefit for patients on ACE inhibitors. So the evidence is starting to accrue that these therapies at a minimum are safe to continue, and there may be more, but at this point, a minimum to continue. So that leads us to, all of these questions lead us to where we got to with the AHA registry. So about 2 years ago, I led a collaboration. I led the initiation of a collaboration of, it started with 8 sites, the sites in red, and then additional blue sites have been added in the past 6 months to a year. These were sites who are interested in collaborating and understanding what are novel, innovative approaches to providing cardiovascular care to achieve better outcomes for our patients at lower cost. And so we initiated this collaborative called the Cardiovascular Quality Improvement and Care Innovation Consortium, and had been actually drafting a white paper of the work that we were doing and how we anticipated going forward earlier this year. Right at that time, as COVID began to emerge, we started to have conversations with each other about how do we leverage our consortium for COVID-19, and started to share what our protocols were for inpatient evaluation, prognostic laboratory markers that would inform anticipated course of care as we continue to generate knowledge about how we should best manage, trying to share these practices. We have we have New York Presbyterian involved in this conversation. So obviously conversations with that site were particularly informative and terrifying at the same time. But as a result of these conversations, this then led to conversations with the American Heart Association. The American Heart Association runs a registry, or a number of registries, through what's called the Get With the Guidelines program, this concept of capturing data from hospitals to how they're performing relative to guideline care for cardiovascular diseases, including MI, stroke, heart failure, and in-hospital resuscitation. And in partnership with AHA, we've initiated this COVID-19 Cardiovascular Disease Registry. We want the initial email in our group was in March 20th, and 2 weeks later, we had announced this registry. And the intent of providing sufficient data is our first step in understanding the impact of COVID-19 in cardiovascular health. So what's included in the registry? The registry includes all hospitalized patients with active COVID infection. Again, it leverages the existing Get With the Guideline program that includes over 1,000 participating hospitals at this time. Our hope is to include as many of those hospitals as possible, and potentially additional hospitals beyond that, as there's no participation in the program. The cost relates to how individual sites will have to go about capturing the data, either through data abstraction or leverage of existing data resources. This will provide systematic capture of real-world practice patterns and outcomes. Our hope is to address clinical questions around issues of risk prediction, effectiveness versus efficacy, And this data will hopefully inform clinical practice guidelines and provide benchmark of best practices and outcomes. Currently, we don't know what best practices and outcomes are, but by benchmarking hospitals against each other, identifying sites that appear to be outliers in terms of better outcomes, we can start to evaluate what processes do they have in place that are achieving those high quality outcomes. And then I wanted to just briefly touch on the registry timeline, as I feel it's been very impressive. Typically, these types of registries take years to get going, from concept to case report formalization to involvement of the AHA in getting sites onboarded. We've compressed that into essentially a 1-month timeline and have already captured data on some of our first cases. So again, that initial email conversation between the CV Quick group on March 20th. By April 2nd, we had a steering committee. By April 19th, we had our first version of the case report form finalized. April 16th, we finalized our operations committee. So this is the committee responsible for both participate and identifying what is the data necessary to feedback to sites to be informative about how to modify and adjust best practices. By April 23rd, we had formalized our research and publications committee and started to draft what would be our strategic manuscripts. By April 24th, we had our first cases entered from more than 40 sites. And by April 28th, we were already working on our second version of the case report form. So a tremendous speed with which we've moved this forward, recognizing the need for speed in generating answers. I'll just briefly touch on example data elements. So again, these are examples. This is not the full case report form, but includes demographics, medical history, therapies prior to admission, vital signs, values, inpatient therapy, their cardiovascular therapy and outcomes in the hospital, inpatient interventions, and their in-hospital outcomes. We will not ask sites to capture long-term outcomes, but we will leverage existing knowledge of how to link this type of data to Medicare data to evaluate long-term outcomes. And then reporting back to individual sites, some of the proposed reporting measures would include in-hospital mortality, ICU, mechanical ventilation, length of stay, differentiated by both ICU, mechanical ventilation, and lack of neither of those needed therapies, and then particularly cardiovascular outcomes. And then management, so continuation of ACE-ARBs as we continue to understand the impact of that therapy, VTE prophylaxis as we continue to recognize the higher risk of that therapy, the higher risk of that complication in patients with COVID infection than COVID-specific therapy. So with that, I'll summarize and turn it over to Dr. Garcia, but the implications for COVID-19 for cardiovascular disease and of cardiovascular disease for COVID-19 are immense. Our hope is that the AHA COVID cardiovascular will provide high quality and multi-center real world data to inform best practices. And as a result of the leadership of MHI, the foundation, and HDI, we have a foundational role in that registry work. Thank you very much, and look forward to hearing from Dr. Garcia.
Well, good morning, everybody, and thank you, Steve, for a great presentation. This is similar to Steve's presentation. This is something that we've been working on for the last month with the foundation and other organizations. And it is, in a sense, I think, complementary to what Steve has been talking about. You may be wondering why interventional cardiologists are getting involved in a viral respiratory illness. As it turns out, about 20 to 25% of these patients do have myocardial injury, and as Steve mentioned, this is a marker for increased mortality. Many of these patients present with ST segment elevation, and emergent angiography has revealed a variety of findings, going from normal coronary arteries to typical obstructive disease that we see in STEMI patients. And these patients, whether they come to the cath lab or not, seem to do very poorly in some series with mortality rates that are significantly higher than what you would expect for a STEMI patient. It's also the presence of myocardial injury, a marker for requiring ICU and mechanical ventilation. So once again, this was incredibly fast, and we try to really respond to this pandemic in a timely fashion. 3 societies have come together to try to answer some of these questions. SCI, representing interventional cardiology in the United States, its Canadian equivalent, CAIC, and the Interventional Council of the American College of Cardiology. It's amazing what physicians can do when there is no travel. We developed a protocol after 2 conference calls and multiple iterations on Google Docs. We already submitted the methodology manuscript for publication in the American Heart Journal, submitted a grant to support this. The American Heart Association, ALINA, has already provided approval of this protocol, and we share that with all the sites. We have over 114 sites, and this changes every day. This is data from last week. We have already requested information. We have 6 sites that are active and enrolling, another 6 that have already obtained IRB approvals, and another 5 data that have already sent us back the data sharing agreement. The goals are fairly straightforward. We wanted to create a multi-center database of patients who are either PUIs, persons under investigation, or COVID positive, and either present with ST segment elevation or a new onset left bundle branch block, or develop these abnormalities while in the hospital. We wanted to compare demographics, baseline characteristics, and outcomes with the group that we have in our foundation of over 15,000 STEMI patients from the Midwest STEMI Consortium. And our final hope is that we can create data-driven treatment plans that can inform decisions about therapy and who needs to come to the cath lab. And briefly, for those of you not familiar with the STEMI Consortium, this is a collaboration of 4 sites spearheaded by team. These 4 sites, in one way or the other, have modeled what we do at MHI with our level 1 program. There is one, and in some cases, more than one PCI center that has established relationships with non-PCI hospitals. The 4 participating centers are listed here. We have Iowa Heart Center, we have Prairie Heart in Illinois, and the Christ Hospital in Ohio, in addition to our site. And Christian and Ross have done a wonderful job at merging all these databases. So now we have over 15,000 patients included. And the strengths are that all these hospitals have very similar protocols, similar alerts to activate the cath lab, in many cases bypassing the emergency department through pre-established transport routes. We also collect similar information regarding demographics, medications, and time data. And perhaps more importantly and unique to our registry is that we collect not only in-hospital outcomes, but we extend follow-up up to 5 years, and in some cases for mortality up to 10 years. So we have the opportunity to look at longitudinal data down the road. Going back to NACME, these are the inclusion criteria. They're very simple. We want either COVID positive patients or PUIs who present with ST segment elevation or new onset left bundle branch block. We want to focus on adult patients, and we want to restrict patients who have some sort of clinical correlate of myocardial ischemia. Now, this does not have to be chest pain alone. We want patients on a ventilator, patients cardiac arrest, shock, and other manifestations of COVID-19. We have no exclusion criteria for this registry. Now, to give you an idea of different pathways that will lead to participation in NACME, we have on the left, the first patient suspected COVID-19, not confirmed yet, who presents with inferior posterolateral STEMI with Q waves, a clinician made a diagnosis of a coronary event, and the patient underwent PCI. Later on, the patient was ruled out for COVID. We still want that patient in the registry, even though it was not confirmed. We want PUIs, and we have dedicated analysis to compare the outcomes of PUIs versus COVID patients, because as I will explain later, COVID seems to be affecting many aspects of STEMI care. So this is going to be one of our objectives. The second patient is a confirmed COVID patient that has this Brugada pattern on his EKG. This is oftentimes triggered by fever. He was clinically diagnosed with a non-coronary event, did not come to the cath lab, did not receive thrombolytics. Those patients are still eligible to participate in ACME. And finally, the patient on the right, this is a patient with a confirmed COVID who, for whatever reason, local protocol, local practice, underwent thrombolytics, and then was taken to the cath lab for successful angioplasty. So I want to make clear this is not a cath lab study. This is a STEMI registry, and we want to include patients that receive stents, that receive thrombolytics, and patients that are treated conservatively. And we also want to include patients that are PUI. These are some of the questions that we have. We're trying to get answers. Who needs to come to the cath lab? And what are the most important angiographic correlates? Are they similar to the non-COVID patients? And that's what we intend to use our Midwest STEMI Consortium as our control group. What treatment works best if there is a significant number of patients that are receiving other therapies other than primary PCI? As you know, this has been advocated by many outside the US. And we hope to make data-driven recommendations that are helpful to clinicians. And perhaps as important, try to understand also how COVID-19 is affecting the care of non-COVID patients. So who needs to come to the cath lab, and why is this is important? As you know, this has been widely reported. There are shortages of PPE. Healthcare workers are significantly affected by this. In Spain, 13% of COVID cases are in healthcare workers. And the other issue is the diagnostic tools that we have today. Usually we don't get an answer within 1 hour or two. So we have to make decisions as to who comes to the cath lab without a complete picture. Understanding that in some cases we may be taking calculated risks. And so that was one of the rationales for including PUIs. And this may change as the clinical diagnosis testing evolves. There is also a need to understand these modified reperfusion strategies, and this is some of the rationale for investigating these strategies in COVID patients. Even prior to COVID, about 13% of STEMI patients in the US received some form of pharmacological reperfusion, either alone or as part of a facilitated PCI strategy. This is called the drip and ship approach, which we use for our level 1 patients in zone 2. Given its efficacy, some have made the case for using thrombolytics as first-line therapy if patients present with low-risk features within 3 hours of symptoms onset. The idea is that thrombolytic therapy could potentially mitigate delays in reperfusion related to testing and other things that we do in the emergency department. And perhaps door-to-needle time during the pandemic may be shorter than door-to-balloon time. The proponents of thrombolytics also suggest that resource utilization and PPE may be favorably affected by this strategy. And finally, this algorithm has retained emergency PCI as a bailout strategy for patients that are deemed high risk or those who fail reperfusion therapy with pharmacological agents. Now, my personal sense is that this is not a great idea. And this is actually a case that happened in town, and this is a PUI that presented with inferior ST segment elevation, was taken to the cath lab and had normal coronaries. And this is the CT scan. I mean, I will be very, very careful about giving thrombolytics to patients who have this type of radiologic evidence of disease. I don't think this is something that has been advocated broadly in the United States. In fact, both SCI and ACC have made the case that during the pandemic, we should continue to offer primary PCI to these patients. But hopefully we will collect some data in Canada. Some centers are doing this, and we plan to include them in our registry. So what do we know about this entity from the early experience? This is something that was published in the New England Journal of Medicine with only 18 patients who presented to a New York hospital system with ST segment elevation. Now, a few things of importance here. About 50% of these patients had ST segment elevation at presentation. The other 8 patients in the study developed ST segment elevation during the hospital admission. And the median time to presentation was approximately 6 days. Of these patients, the clinicians made diagnosis of a myocardial infarction in approximately 8 of them. The remainder 10, they had what they call non-coronary myocardial injury. And I would take that diagnosis with a grain of salt because not all of these patients underwent angiography. A few things of importance: the minority of these patients presented with chest pain. Only 33% of them had chest pain. The most common symptoms were fever and cough. Some of them were intubated, and cardiac arrest was not uncommon. When you look at strategies here, you can see that what they call STEMIs, or traditional STEMIs, here is depicted in blue, the non-coronary myocardial injury in orange, and the mortality overall was exceedingly high, 72% mortality for these patients. And the use of coronary angiography was not a predictor in this small series of success. 50% of patients underwent angiography. Of those patients, 6 out of 9 had obstructive disease, and 5 underwent PCI. The deaths occur in both groups. The outcome of patients with non-coronary myocardial injury was dismal. 9 out of 10 patients die. The 8 patients with STEMIs, 4 of them die. Some with PCI, some without PCI. So how do you make this call? Who has an MI versus a non-coronary myocardial injury? It's hard to make that call based on the EKG alone. As you can see here, these 2 cases, in my estimation, I think in most hospitals, both will be coming to the cath lab. The authors have advocated, or perhaps used in their own experience, biomarkers, troponins on the left and D-dimer levels on the right. And as shown here, you can see that there is significant overlap between these 2 groups. And I think it will be very, very challenging to make that call based on these biomarkers alone. Hard to neglect or label as a non-coronary myocardial injury troponins of 80 or 40 or even 13, as shown here. So perhaps higher levels in typical STEMI patients, but significant overlap between the 2 groups. What about imaging? Imaging has been advocated as a way to risk stratify who needs to come to the cath lab and who can be treated more conservatively. But in general, those patients that have diffuse ST segment elevation with preserved ejection fraction without regional wall motions, the majority of those patients were labeled as non-coronary etiologies and did not come to the cath lab. On the right side of the algorithm, the majority of patients who had focal ST segment elevations had depressed ejection fraction and regional wall motion abnormalities, and the majority of those patients did come to the cath lab for emergency angiography. So the use of bedside ultrasound or point of care ultrasound has been advocated in the emergency department to decide or perhaps help decide who needs to come to the cath lab. Moving on to another aspect, which has been, I think, interest of our group to understand and follow in the pandemic is what's happened with the non-COVID STEMI. We all noticed a significant drop in volumes that went from being an anecdote to being something that we could quantify. We made this observation last month looking at STEMI activations in 9 high-volume PCI centers. We wanted to have centers that were part of the Midwest STEMI Consortium, but also centers that were in the hotspots in the East Coast and also in the West Coast. And we noticed a significant 38% reduction in STEMI activations. And this is not something that we expected. In fact, there is data from previous pandemics with influenza showing that the number of heart attacks tends to increase. And so this is not a finding that we could explain on the basis of COVID alone. Where are all these patients going? It is not clear. We notice these drops across the board. It doesn't really matter if you are in a hotspot area or if you are in the Midwest or in other areas where COVID has not been as devastating. Every single program has noted a decline, as shown here. We think that many of these patients are actually dying at home. This is data from New York City, and the number of 911 calls has increased significantly. The number of cardiac arrests has increased significantly. And most people attribute this to COVID-19. We think that that's possible, but many of these deaths are cardiovascular emergencies that went untreated. And this could be a serious concern if this trend remains, and why patients are avoiding care is something that really needs to be investigated. Perhaps the message of stay at home if you're short of breath, you have COVID, needs to be recalibrated in light of this data. We're also seeing the flip side of the coin, which is those patients that do come to the hospital are having more mechanical complications post-MI. I will just show you quickly 2 cases that Dr. Al-Sidawi has put together for JAC case report. This is a patient in her 60s who presented late after an inferior MI with shortness of breath, thinking that she had COVID, did not seek medical care initially, had an occluded RCA that could not be recanalized, and was admitted a week later with an apical VSD. This was followed by another patient the following week who was short of breath for 2 weeks at home, thinking that she had COVID, and presented with an anterior MI and no chest pain, heart failure, and another VSD. This patient refused further care and was sent to palliative care. So to conclude, I would say that COVID-19 seems to be affecting STEMI care at multiple levels, and we need to be thoughtful about how potentially this could be affecting non-COVID patients. Observational registries have certainly gained traction in cardiovascular disease, and they can be useful to provide benefits and potential harms of different strategies. Our final goal is really to try to obtain actionable data. There is a lot of opinion at the moment as to what's best, but I think we need data to make recommendations. This pandemic is not going away anytime soon, and we hope to be able to provide data in the next few months. We believe the registry, because it's multicentric, involving 2 countries with different healthcare systems, will provide useful information to clinicians. There are 2 other registries that SKY is sponsoring. One is MCS registry that Naveen Kapoor is leading, Tufts University in Boston, and then there is another registry looking at different PPE practices across cath labs in the country that will also be hosting at MHI. It will not be fair for me to finish this talk without saying thank you to a lot of people who made this possible. In particular, those listed here. Ross has been wonderful in supporting this registry and attending every single Zoom meeting that we had over the last few weeks. Christian, Kerry Thomas, I'm sure they remind me every day when they open their inbox and they see 150 emails asking about NACME. Scott Sharkey and the foundation have been very supportive of this effort. And also I'd like to thank my co-PIs, Tim and Payam, who is the representative from Canada in this effort. With that, I will conclude, and I think we should open it up for questions if you have any.
All right, well, thank you very much to Drs. Garcia and to Dr. Bradley for presenting. Those were great presentations. As a reminder to attendees, please enter your questions or comments into the Q&A pod located at the bottom of your screen. And to start things off, Dr. Garcia, is the NACME registry already enrolling patients?
Yes, it is. We are active and enrolling patients. We have already started to receive CRF from sites. So the answer is yes.
Oh, great. Another question for you, Dr. Garcia, is there an interest to leverage the NACME registry to capture and centrally analyze clinical CMR studies that have been performed during the course of hospitalization to understand patterns and extent of myocardial injury?
Well, interesting question. We personally, I think some of us had interest in that and understanding different patterns of myocardial injury. My understanding after discussing this with Joao Calvacante is that the MRI Society has recommended not to take these patients for MRIs in general because of the risk of exposure, etc. So we did not think it was going to be worth it to include MRI data in our CRF.
All right, thank you for that. Another question for you, Dr. Garcia, is your point about fever and the Brugada pattern is a good one. Have we seen any COVID-19 patients with ST elevation and non-obstructive coronary disease at MHI?
Not at MHI, but I have a handful of cases that I can recall from talking to friends and partners in other parts of the country, New York City, etc. Yes, it's something that has been well described. It's already in the literature and something that we need to be mindful of. And I almost believe that I've seen some sort of editorial in JACC from Dr. Brugada about it. So it has been well described.
Thank you. So this question is for Dr. Bradley, and that is, do we know if ACE2 levels differ significantly in Caucasians versus African Americans?
It's a great question. I think it's getting to what's been observed in differential both infection rates and risk of mortality in non-white populations. I know that there are differences in ACE blame, and this relates in part to response to things like ACE inhibitors amongst non-white populations. Whether or not that translates to activity levels in non-white populations, I don't know offhand. More importantly, I think that the differences that we're seeing in COVID infection and mortality rates among non-white populations speaks to differences in ability to follow things like social distancing because of what life is like based on different socioeconomic status. It's very challenging if you live in dense housing and multi-generational families. Avoid spread of an infectious disease throughout that family at home. If someone still needs to go to work because they're considered an essential worker or because they just need to. And even in Minnesota, where we know our demographics do not look like they do in New York, we're seeing the rates of infection. About a third of patients who are hospitalized with COVID are non-white, as are a third of mortalities. And that reflects a significant misrepresentation of what our demographics look like, and this is hitting those populations very hard.
Thank you for that. A couple more questions here, and this one is again for Dr. Bradley. So does COVID-19 differ from influenza with respect to mortality risk imposed by coexisting cardiovascular conditions?
I think that it's important to differentiate absolute risk from risk. So the absolute risk of COVID infection and mortality is much higher than it is for influenza. The relative risk in terms of risk of mortality amongst patients with cardiovascular disease conditions, we haven't really compared. but certainly hypertension was not something that we typically think of as being a predominant risk factor in patients with influenza in the same way we're seeing for COVID.
Great, thank you. So would there be a possibility to leverage EHR to timely capture the hospitalization clinical data for the AHA COVID registry?
Not sure what the question means by timely capture. So I think one of the things that we've been pushing on AHA and other registries for years is this concept that all data should be abstracted by trained nurse abstractors. Moving forward in the recognition that many sites, including our own, have data structures such that a lot of this data can be pulled from the electronic data warehouse without requiring additional chart abstraction. So we are moving forward in ways that allow that to happen. There are efficiencies gained from that, but it also requires technological aspects of data uploaders, and those are being built on the registry side. So there will be some efficiencies gained there and minimization of need for chart abstraction for data collection.
All right, thank you. This next question is a little more general, and that is, has anyone looked at the ethnic makeup of the healthcare workers affected with COVID?
I don't know off the top of my head. And one of the challenges of trying to stay up with the COVID literature is something that was published a week ago feels like it's about a year old at this point. So there may be, but I don't know specifically.
Okay, thank you. The last question we have here is from Dr. Gessel, and he would like you guys to speculate on if STEMI mortality is 80%, what do we currently think is going on to make a difference?
Well, I think that's the challenge, is to try to understand why these patients are having such high mortality. Certainly, as most people in the call know, the mortality for STEMI in 2020, uncomplicated, is in the very low single digits. So this is substantially higher and not something that we fully understand. But obviously, many of these patients, as I show here, have presented with cardiac arrest, are in shock, have respiratory failure. And data from New York suggesting that if you go on mechanical ventilation, your odds of survival are very, very low. And so I think we need to understand more about this disease and why it's different, and if all our efforts of taking these patients to the cath labs and potentially contaminating an environment and many people involved are worth it, or this is something that once you are in this trajectory, there is no much that we can do. Those are the real questions that we need to understand, and we hope that the registry will provide some information. But the early signals from New York are very concerning with regards to mortality, and not essentially in sync with what we've seen from China. The Chinese have reported significantly lower mortality for STEMI patients, taking a more conservative approach. So I'm not even sure we're looking at the same disease here, and that's why we need to understand this better.
Well, I'll chime in there and add that, in fact, that they weren't, because there are tremendous challenges in accurately reporting what's happening when we are reporting studies from patients who are yet to be discharged. So one of the challenges from some of the New York papers were that they reported mortality for a subset of the population rather than the entirety of the population in something like patients were still in hospital, so hadn't been discharged. We can't know their outcome yet. And so by misreporting, they reported an 88% mortality, which was erroneous because they failed to account for patients that were still in hospital. So these will be challenges for all of our registries to ensure that we don't over-report those for whom we know the discharge status, either because they had a very short length of stay or because they died early. Because we're finding that on about a third of patients are requiring ICU stay, the average length of stay for those patients is significantly longer, and some of those patients are requiring up to 3 weeks of ventilation care. So very challenging to understand the true mortality if you misrepresent who's in your cohort.
All right, thank you very much. It looks like we have just a few more questions, and the first of which is to both of you. What is your opinion about the proposition of fibrinolysis, sorry for the pronunciation, versus primary PCI for STEMI treatment, which has been circulating in other publications?
Well, I'll go first, Steve, so you can take the counter argument. But I'd say that I'm against it. I think the rationale is weak, in my estimation, is probably doesn't apply to the United States, where we have plenty of PCI capacity. We have more PCI centers than Starbucks, and they're not particularly busy at the moment. So the argument of a lack of PPE or others, I don't think really are applicable to our healthcare system. In addition to that, I would be very concerned about giving thrombolytics to patients that may have, clean coronaries and no coronary artery disease. So I think I'm not necessarily married to PCI, but I think understanding the anatomy before you commit to a therapy is important. The risk of bleeding in these patients that have abnormal CAT scans and lung disease in the ICU, I would imagine is substantial. So outside of very unique situations where it may be justified, I do not think we need to deviate from our usual care.
I would agree with that wholeheartedly. I think some of this came from as systems were trying to anticipate a surge of COVID patients and understanding how we were going to care for these patients if we were so overwhelmed that we didn't have capacity to take patients to the cath lab. But that hasn't borne out. And so I think that to Santiago's point, that as he was seeing Joao's question, so that's why I said, to Santiago's point, we have the capacity. We know that it's a more effective therapy. We also know that it results in lower length of stay and the priority. All those reasons point to PCI being a preferred therapy. We aren't at a point where capacity is such that we need to think about returning. And I think that was what drove some of the concern, but I think to agree with Santiago wholeheartedly.
All right, looks like we have one more question, and that is ischemia the proposed cause of electrical instability in the cardiac arrest patients, or does there appear to be a primary myocarditis going on in the non-coronary myocardial injury patients associated with COVID?
Well, I don't think we know. I think it's probably a combination of things. This basket of COVID STEMI patients is very heterogeneous. And if you go to the cardiac arrest patients, perhaps even more so. There have been cases reported of myocarditis, congestive heart failure as a manifestation of the disease. Primary STEMIs have been reported as well. Steve showed data that some of the therapies that we're using, experimental therapies, are causing QT prolongation and arrhythmias. So I think it's probably multifactorial and varies from patient to patient. We are collecting EKGs as part of this registry, so we hope we can try to answer this question with NACME.
All right, well, thank you very much. It looks like those are all the questions that we have. Doctors Bradley and Garcia, is there anything else that you'd like to say?
No, thank you. I think this is, there's a proverb of may you live in interesting times. I wish times were a little less interesting, but I think it's great that we have an opportunity to lead in understanding this situation that we're in and trying to provide the best care for our patients.
Well, thanks to the foundation. Everyone has been very supportive of these registries, and thank you everybody for calling in so early on Monday morning.
Have a great day.
Good day. Bye-bye.
All right, thank you.